Hey guys, Michael here. Just gonna have a quick chat about chest drain transportation as we head through this quick video. So chest drains are used to facilitate the drainage of fluid and from the pleural cavity by using a one-way valve that prevents the backflow of fluid and back through into the chest. It's most often used for us. It'll either be post-surgery in a hospital in a smaller hospital that then may need a patient to be transferred to a larger tertiary hospital. And it's also used when there's a collection of fluid, blood, and air in the pleural space post tension pneumothorax or a hemothorax. And it assists in the draining and collection of this fluid and restores gas exchange. Um, we have to make sure that we're aware how to manage these patients, particularly because in the back of a moving ambulance heading from one hospital to the other. Ultimately, if there's an issue, we need to be on top of it and be able to troubleshoot and fix this pretty quickly. Now, the equipment that's required is you need one of all the bits and pieces that are attached to the patient. So you've got your atrium chest drain box itself. It looks like a nice little box there. You also need to have access to suction, oxygen cylinders, preferably a spur box, a second atrium box if possible, spur dressings, tubes, drain clamps, as well as making sure you're always wearing your PPE, your gloves, your goggles, face masks, and analgesia for the patient as well can often be quite helpful. So when you arrive at the bedside of the patient, you want to make sure you have a thorough handover, clinical handover from the nursing staff and the doctors that are on site and have been caring for this patient prior to yourself. Whilst you appreciate the hands-off time while you have a clinical handover, you then want to make sure you do a full review of the whole system system setup yourself. So you want to observe the drain insertion site, check for any signs of infection or inflammation. You want to make sure the dressing is clean and intact. So this is going to make sure there's no obvious signs of leakage through the site. There's no blood that's coming out through the site. You want to make sure that the tubing is actually quite secure to the patient, the sutures are in place, and that all the bits and pieces of the tube towards the chest drain are secured and aren't going to catch and pull the tube out. You want to ensure that the connections are locked into place. There's no kinks or obstructions through the chamber at all. And then obviously having worked your way from the patient insertion site down to the atrium chamber itself, you want to then go through and make sure that the water level in the water seal chamber is at that 2 centimeter mark. You want to make sure that there's an obvious swing on the right hand side there. You can see the markings that a 0, +1, +2. You want to make sure that that little white ball there is traveling up and down that with the respiratory cycle. You want to make sure that there's no actual air leakage at all. So air leakage will be shown by bubbles coming through from where that white ball is on the bottom right hand side, and the severity of the leak is indicated by how far the bubbles progress across that 1 through 5 scale, 1 being minor and 5 being quite extensive. So you're also going to monitor the amount of fluid that has drained through the chest drain. Obviously, it's going to start filling from the right-hand side, the smallest demarcations down at the 10, 20, 30, 40 mils. And as it progresses, it's going to head all the way up to 2,000 mils. Now, you also want to make sure you have that spur chamber because as it gets to about 3/4 full, that's the point in which it's maybe warranted that you have to change the atrium box itself. So perhaps the most important part of managing a patient with a chest drain during transport is the ability to be able to quickly and accurately troubleshoot any potential problems to ensure that drain continues to function properly and doesn't cause any issues for the patient. It can quite easily have ramifications such as redeveloping a tension pneumothorax and quite significant ventilation problems. So this table here just shows a few quick tips and tricks in regards to what you might see and how you might fix it and what the cause will be. So if there is continuous air bubbling coming from the chamber down in the bottom left-hand corner of the box, then potential cause is obviously as a disconnected system. There's an air leak somewhere in the system. So best way to sort out where that leak is coming from, if you start proximal to the patient, you check the actual insertion site, you start clamping further and further away from the patient and see at which point the bubbling stops. You can then determine whereabouts on that in the circuit there is leakage, and you can either try and reinforce the tube or the insertion site, or you can address any kinks or problems like that have happened. A cessation of bubbling is, like I just said, sorry, the cessation of bubbling is a possible kink. So you want to check the whole circuit, make sure there's no obstructions. There could even be a clot that has formed at some point, or if the tube itself is dependent and hanging lower than the box itself, it can also cause a few issues in terms of fluid mechanics. If there's a cessation of the swing, issues with the swing, it can head towards those positive numbers if there is a PEEP system in situ. But if there is a cessation of the swing, then you may be suctioning, there's a blocked or occluded chest drain. Once again, you just got to check for those clots or kinks. Now, if there's an issue in which the tube is accidentally pulled out, so it gets caught on something, it comes out, then obviously at this point we're not able to put a tube back in ourselves. So we want to make sure that we can address this issue in the best way possible, and that's going to be by applying a three-sided sterile occlusive dressing. So it acts as a three-way valve almost, sorry, a one-way valve in itself, and you can expedite to a facility in which it can be addressed a bit better. And finally, as we are in the process of transporting this patient, you want to make sure that you're documenting any changes to patient condition. You want to note how much fluid is draining by the hour, the colour, the consistency, if there is the presence of or bubbles at any stage, and what you did to fix that, and where the cause, what the cause was identified to be. You want to make sure that the swing is consistent to what you'd expect, and document also any issues that the patient may have in regards to pain or respiratory compromise secondary to problems with drainage, perhaps. You also want to make sure that you're very, very regularly documenting the patient's vital signs with frequent respiratory assessments. So you want to be auscultating the chest quite regularly. You want to make sure that if there is any change to that patient condition, that you're already on top of it. You can look for ways to treat it and make sure that this patient is receiving the best care possible moving forward, particularly with the massively increased likelihood of a pneumothorax or a hemothorax occurring during transport. You've got to be on top of that quite quickly, obviously both life-threatening conditions.